To be presenting today on the initial trauma care ITC protocol, as well as the trauma triage and transport criteria protocols. What will we be covering? Again, the initial trauma care SOP. We'll be reviewing spinal immobilization because it is covered in that protocol. We'll also be going over the trauma triage transport criteria, helicopter guidelines, special considerations. Something to take into account, these two protocols cover about 3 pages of the SOP book. COVID has affected things in the protocol. It does cover CPAP as well as traumatic arrest, protective equipment, just a few things to think about. To start, initial trauma care, the ITC protocol, scene size up, situational awareness, dynamic risk assessment, assess and intervene as needed. Scene safety, our number one concern overall, as always. Mechanism of injury, is it a car accident, somebody cutting down a tree and got whacked by one of those, burns, other type of things, obviously. Anticipate the type and severity. We can use dispatch to our advantage for stuff like that. They're getting really good at collecting information for us. And we want to make sure we use universal precautions and PPE. We just covered that with the COVID stuff. Again, dispatch comes in big handy to cover the number of patients, possible additional resources as needed prior to us getting on scene. And then we need to make sure that we're bringing things that could be essential to patient care, hemorrhage control, airway and O2, splinting, spine equipment, as well as pain management and vascular access. Initially, when we arrive on scene, we're going to gather a primary assessment. Once we are given a patient, or after we figure out how many patients we have, when we start our ambulance's care on one patient, age, gender, weight, general appearance as we're approaching them in the vehicle, position, surroundings, any obvious injuries, life threats. If immediate life threat exists, we can treat the life threat and resuscitate if needed. Level of consciousness measured by AVPU or the Glasgow Coma Scale, their chief complaint, and if they're unable to verbalize one, any signs and symptoms that we can gather or anything we can gather approaching. Hemorrhage control first. Priorities change if exsanguinating external hemorrhage. If we need to throw a tourniquet on somebody, that's going to go first. Airway, breathing, circulation. The first thing on this list is airway and spinal injuries. Consider spine injuries. Other than that, we're going to want to open and maintain the airway using positioning. If we need to, jaw thrust or a head tilt chin lift, suction as needed, appropriate adjuncts, NPA or an OPA if we need to, measure from the corner of the mouth to the ear or the nose to the ear, manual spine precautions if needed. Once the airway is controlled, we can apply a C-collar and use a backboard or a kedboard. Take caution, vomiting and seizures. Once we figure out if they do have an airway, we can assess the adequacy of ventilations and their gas exchange, how well they're moving air, symmetry of their chest or eyes, accessory muscle and retraction, lung sounds if we can get those. Note an SpO2 and an end-tidal CO2 as well, and then correct hypoxia. Put them on O2 if we need to. We're pretty good about putting people on cannulas, non-rebreathers, or when to bag somebody. Let's just make sure that we remember to hook that up to O2 and also make sure that we can get a surgical mask over that device if needed. Remember, if we got to start bagging somebody in a vehicle or in a position that is uncomfortable, don't forget we do have PPE precautions that we need to try our best to keep in place. This covers CPAP right here. Per appropriate SOP, this is saying tension pneumo or an open pneumo with the flail chest. Again, we're not doing CPAP right now, so take that into account. The SOP says that, but remember what is current with the COVID protocols. SMR, and the slide before this, it mentions spinal restriction or spinal motion restriction, so I just want to cover that real quick. These are things that are more likely to get backboarded. Acutely altered level of consciousness under 15 without evidence or even with evidence of intoxication and a mechanism of injury. Midline neck or back pain or tenderness, focal neurological signs or symptoms, a numbness or motor weakness, anatomic deformity of the spine, distracting circumstance or injury, so a long bone fracture, a degloving or a crush injury, a large burn, emotional distress, communication barrier, etc., or any patient that impairs any injury, that impairs patient's ability to contribute to a reliable exam. Contraindications to spinal motion restriction is penetrating trauma to the head, neck, or torso. SMR continued. Methods of providing SMR. Manually stabilize the head and the neck. Don't pull traction. And unless it's necessary to do so, then that's what we should be doing first. If the exam is normal, have patient moved into axial alignment. Stop if pain or resistance. Apply a C-collar unless contraindicated. Extricate patient. Have them move out. SMR cannot be properly performed with a C-collar only or a patient in a sitting position. So if we're going to be putting somebody in the motion restriction stuff, we need to lay them flat and need to use more than just a collar. Continued again. Fill the voids if necessary. If somebody has a hunchback or they're a kid that isn't really laying comfortable or an older person, try and fill the spots if we can. Maybe put a blanket down on the backboard prior to putting them on it. Make sure that we use appropriate straps, spider straps if needed. We do have a PEDS backboard on the ambulances that we could use as well. All patient transfers create potential for unwanted displacement and of an unstable spinal injury. Just be careful to moving a patient from the car to a backboard to the cot. I guess that's what that's saying. Once the patient is positioned safe on an ambulance cot, transfer or extrication devices may be removed. As far as a KED board, you can put them on a backboard and remove the KED. As long as there is an appropriate amount of people there to make moving minimal. You want to minimize unnecessary movement during the removal process. The risks of patient manipulation must be weighed against the benefits of device removal. If transport time is short, may transport patient on device and remove upon arrival to the hospital. If extrication device is removed in the field, SMR should be maintained by assuring patient remains securely positioned on the cot with a C-collar in place. If altered mental status and non-responsive to verbal commands or uncooperative and remaining still, assess the need for sedation. Obviously, we can give them Versed at the appropriate dose. C, not CPR in this case, it's circulation. We're going to assess their perfusion. We're doing most of these last couple of slides pretty quick within the first 3 or 4 minutes of the call, maybe even faster. So you want to compare radial and carotid pulses, assess their skin color, the temperature and moisture levels. If there's no carotid pulse and you can't find a pulse anywhere else, start the traumatic arrest SOP. Again, we have COVID protocols in place as far as CPR is going, so please make sure that you are wearing appropriate PPE and using the plastic sheets if needed. Assess bleeding type, amount, source, and rate, and hemorrhage control per system procedure. Try and be able to plan appropriately if direct pressure isn't working. Be prepared to move on to pack the wound with the hemostatic gauze and then check again for the frequency of bleeding, or just put a tourniquet on it if you feel like that's the step that is appropriate. If they have a possible pelvic fracture, you can wrap them with a pelvic binder, a sheet, or an upside down KED board. I trust the judgment that you guys have out there, so if you feel like jumping right to a tourniquet is best, then maybe that is best. And if we are going to be starting an arrest for the traumatic arrest SOP, try and make sure that everybody is aware of what's going on the scene. You don't need your extrication guys getting too involved and too close to patient care. If you're going to be working the arrest, you want to make sure that anybody within safe distance of the patient has the appropriate PPE on. Okay. If you do suspect a cardiac tamponade, blunt aortic, or cardiac injury, follow appropriate protocol. This mentions vascular access. We need to be aware that these people may need a lot of volume replacement. I think we're really good at figuring that one out if they need any volume replacement. We know what type of fluids we need to use, the 0.9 normal saline. If they are in shock, we're going to look for a larger gauge IV. They may need up to 1 liter wide open based on their systolic blood pressure or their MAP, as well as their mental status and the pulses that we can find. Do not exceed the blood pressure that we have set in the blood pressure targets that we have set in the SOP book. Excessive fluids can lead to uncontrolled hemorrhage, hypothermia, hypocoagulable state, as well as abdominal compartment syndrome. So what this is saying is if we flood them out with fluids, we can make them lose their ability to clot, lose their ability to control their own temperature, and that's good for nobody, especially us. They can bleed out right before us if we give too much fluids. Penetrating trauma to the torso, target blood pressure is 80. Again, that's permissive hypotension. Blunt trauma, the target is 90. Traumatic brain injury, the target is 110. And then look out for IO indications if you need to. Hypovolemic shock and active bleeding for under 3 hours can get one of our newer drugs, TXA, 1 gram in 100 mLs of normal saline over 10 minutes. Monitor EKG. Obviously, we want a patient that we're potentially going to be flying out on the monitor. The blood pressure help, a little bit of a guide. The pericardial tamponade, we're trying to achieve 80 systolic. Aortic injury, we're trying to achieve 90. Head injuries, 110. Penetrating trauma is permissive hypotension, as well as the aortic injury is also permissive hypotension. Penetrating trauma is 80 systolic, and then blunt trauma is 90 systolic. With the permissive hypotension, we don't want to give them so much fluids that we're causing them to lose blood and the good stuff out of the bad stuff. Assessment continued. We're going to assess the neuro for disability, a rapid neuro exam, a Glasgow Coma scale, assess their pupils and the ability to follow commands as far as moving all 4 extremities. We're looking for increased intracranial pressure or herniation signs. If altered mental status, blood glucose per system procedure. If they need to be treated for hypoglycemia, then we'll treat them. We can give pain management hopefully as long as they're over systolic of 90. We can give Zofran if they're going to start vomiting, and then expose of the environment. We want to undress as appropriate, keep the patient warm. We shouldn't be starting that till we're in the back of the ambulance. Where do we transport? How to make a transport decision. Consider need for trauma surgeon to the scene. Response per Region 9 policy. I don't know of anybody that's had to do that yet. Transport to nearest appropriate hospital per region triage protocol. We will cover that. And consider seeing use of a helicopter or alternative transport means. Again, we will cover that shortly. Assessment continued, a secondary assessment. So this could potentially be once we're in the ambulance, or maybe after your first assessment, we'll be continuing with the second assessment in the ambulance prior to transporting or the helicopter getting there. We're going to want to obtain a full set of vitals, map if able. Luckily, we can put them on the monitor. It'll give us a map as well as a blood pressure. Do try and get a manual blood pressure so that you can have that for your own awareness on your patient, and then put them on the monitor. We're going to want to trend blood pressures, trending pulses as well. Check a pulse, a respiration rate, temperature if indicated. There's no problem getting a temperature on somebody, even if you got to stick it under their armpit. Just make sure you adjust the temperature, the buttons on the temperature machine. If we can, get a sample history as well as OPQRST from the patient if they're conscious, and then cover allergies, medications, past medical history, last oral intake, and then events leading up to the injury. Rapid or focused trauma assessment, review of systems for DCAP, BTLS, and then we're just doing a head to toe. Head, face, ears, eyes, nose, mouth. We're going to be looking for the things covered on the DCAP, BTLS list. Neck, chest, abdomen, pelvis, extremities, back, neuro, and soft skin tissue. Starting up at the top, we can check for drainage out of the head pupils to see if they react, how big they are, if they're non-reactive, as well as eye movement, if they're able to open and close their jaw. We can check for carotid pulses in the neck, jugular vein distension, sub-Q emphysema, and then C-spine assessment as well. In the chest, we can listen to lung and heart sounds and make sure that they have appropriate chest rise on both sides. Abdomen, signs and symptoms of peritonitis and quadrants, as well as any guarding, rigidity, rebound tenderness, localized tenderness. In the pelvis, we can inspect for any blood, possibly checking the urinary meatus or rectum. We will also want to check for instability in the extremities, or instability in the pelvis. And then we'll check the extremities, inspect for position, false motion, skin color, signs of injury. In the back and flank, note any muscle spasms or bruising, or any obvious deformities. Neuro, we can look at the patient's affect, behavior, cognition, memory and orientation, select cranial nerves, and then motor and sensory or ataxia. Skin and soft tissue, the color of the skin, moisture, temp, and lesions or wounds. Assessment and transport, we're going to continue assessing, reassess vital signs and patient mentation, as well as their response to interventions. Every transported patient should have 2 sets of vitals. Hopefully we figured that one out by now. A stable patient gets vitals and reassessed every 15 minutes, as well as any intervention. And then an unstable patient gets every 5 minutes, possibly more frequently, and then continue to reassess at every intervention. Report pertinent positives and negatives, if you can, over the phone to whoever we're going to. Document a revised trauma score parameters on the green sheet. We will cover that. And then handover report, and we take an EMS timeout once we get to the hospital to allow for an uninterrupted report at the hospital. That's useful to ensure continuity of care, especially if complete and written electronic form is not ready. This is just a review of the Glasgow Coma Scale for adults. Covers 15 points. Eye-opening is worth 4. Verbal response is worth 5. And a motor response is worth 6. And then this carries over, as you can see on the right side of this picture. You take the point system on there and carry it to your revised trauma score. At the top it says Glasgow Coma Score. You write the number down, and then your respiratory rate. You get a number value for that, as well as your systolic blood pressure, and you can come up with your revised trauma score. Transport decision, trauma and transport criteria. This is up at the top of the protocol for the big picture of things that we are potentially going to be flying for, as well as these special considerations or what could go either way as far as nearest hospital, level 2, or what could be flown. I think we do a really good job of that on Woodstock here to see who should be flown and who is okay to go to a Huntley or a McHenry. Trauma patients should be taken directly to the trauma center, most appropriately equipped and staffed to handle their injuries as defined by the region's trauma system. EMS should bypass facilities not designated as appropriate destinations, even if those facilities are closest to the incident. Again, if we're going to be taking people past Woodstock to get to Huntley or McHenry if needed. Let's see, time to fly. These are the patients that are going to be flown without question. Obviously, they are time-sensitive patients. We want to get them to the most appropriate place as quickly as safely as possible. They'll be going to a level 1 trauma center. If they have a Glasgow of 13 or less with head trauma, a systolic blood pressure of under 90 for adults and under 70 for peds. I know it says 70, but don't forget that low blood pressure limit for peds is 70 plus 2 times the age. So don't forget to take that into account. Respiratory rate under 10 or over 29 for an adult, or under 20 for an infant, or the need for ventilatory support. And then moving down, all penetrating to the skull, eyes, neck, open or depressed skull fracture, and if it's blunt trauma, a GCS 13 or less. If they're showing signs of paralysis or all penetrating spinal cord injuries, all penetrating wounds, superficial or deep to the chest or back, tension pneumothorax, chest wall instability or deformity with a flail chest, any penetrating wounds to the abdomen, groin, and pelvis, blunt with hemodynamic instability, extremities and vascular injuries that would have hemodynamic instability with 2 or more long bone fractures penetrating proximal to the elbow or knee, crushed, degloved, mangled, pulseless limb, amputation proximal to wrist or ankle. Possibly fly. This is nearest trauma center level 1 or level 2. So these are the things that we could take to McHenry or Huntley. At the Glasgow Coma scale is 14. Their blood pressure is equal to or above 90 in adults, 70 in peds. Their respiratory rate is within normal limits, 10 to 20. I know it says 29, but the respiratory rate is within 10 to 29 or over 20 for an infant. If they have blunt head and neck trauma with a Glasgow of 14 or 15, suspected isolated spinal cord injury, and they're hemodynamically stable. If they have blunt and hemodynamic stability with a chest and back injury, as well as abdomen, groin, and pelvis injuries, and then if there is hemodynamic stability with 2 or more long bone fractures, amputation distal to the wrist or ankle, penetrating injury distal to elbow and knee for the extremities and vascular. Things that'll go to the closest hospital, traumatic arrest. We may be working those on the scene. Again, we have the COVID protocols. We will have to call prior to starting transport. Call them and see what they want from the hospital. Don't just take them somebody to dump on them, okay? Make sure we keep appropriate PPE. And then also going to the nearest hospital is a Glasgow Coma score of 14 to 15. And then I think we're pretty comfortable with where to go for the nearest hospital on this. Pretty much anybody that is hemodynamically stable has a Glasgow of 14 to 15 and single long bone injury with hemodynamic stability. Special considerations. This is the section that is on the lowest portion of that protocol, the trauma triage transport protocol. These are just things that don't necessarily have to be flown, but are things to take into consideration that may cause injury that maybe need to be looked at a trauma center. Adult falls over 20 feet. Children under 15 years, falls of 10 feet or 2 to 3 times their height. High risk auto crash intrusion, including roof, 12 inches at occupant site or 18 inches at any site. Death in the same passenger compartment. Ejection, partial or complete, from that vehicle. Vehicle telemetry data consistent with high risk of injury. Auto versus pedestrian or a bicyclist thrown or run over or with significant impact over 20 miles an hour. Elderly pedestrians struck by motor vehicle have more than double mortality rate. And then a motorcycle crash over 20 mph. And then again, a special patient populations, just things to consider that may need to be flown or gotten to a specialty center. Age caveats in the elderly, risk of injury and death increases over 55. Systolic blood pressure under 110 might represent shock after 65. Low impact MOI, ground level falls, might result in a severe injury. Children under 15 years of age who meet criteria for steps 1 through 3 above should be triaged preferentially to pediatric capable trauma center if one is available. Anticoagulation and bleeding disorders. Patients with a head injury are more of a risk for this. The bleeding disorder, common bleeding disorders that I've got are hemophilia A, hemophilia B, von Willebrand's disease, and then other clotting specific factor deficiencies. And then burns, severe burns without trauma MOI, consider transport directly to a burn center. All moderate to severe with trauma MOI go to the nearest trauma center. Pregnancy, fetal gestational age over 20 weeks, fundus level with the navel or above, even if they lack criteria for steps 1 through 3. And then EMS provider judgment, any injury from a large animal. Again, I'm pretty comfortable with how much we fly people as well as the things that we fly are appropriate. I don't think we fly things that don't necessarily need to be in a helicopter. I think we do a great job of that overall. Special thanks to Alex Vucha, most of the lovely photography, as well as the system for all of the SOPs. Thank you very much.